All right, can you hear me okay?
Yes, we can hear you.
Okay, I don't hear you. Hold on a second. That's why. Hold on. Okay, let's try again. Can you still hear me?
Yes, I can hear you.
Okay, good. Now I can hear you. Okay, good.
Wonderful.
Okay. All right, now let's see if I can get my screen on properly.
Hi guys, can you hear me as well?
I do, I hear you. Oh, I need a big sign for Pradeep. Let's see. I'll get this on. All right, are you guys seeing my slides now or not?
I'm able to see the slides. Yep.
Okay, is it showing the slide or presentation mode?
Presentation mode.
All right, let's see how I flip this.
If you go to display settings.
There we go.
And then swap. Yeah.
There we go. Okay, good. All right, much better this way.
Very good. We are on live stream on YouTube as well.
As well? Goodness. Oh, and Dr. Abman's online with us already as well. Welcome.
Hi, how are you guys? Hi.
Good, good, good.
Hi, thank you so much for joining us.
Yeah, thank you indeed.
Thanks.
We're excited to have you here.
Yeah. Great, good.
Very good. So this is my first time streaming on YouTube, so I'm going to feel kind of cool for my 16-year-old when I tell him that. Looking forward to that. He never thinks I'm cool, so this is something I got.
This will help. This will help.
This will help, exactly. So Steve, you've been at Buffalo for a long time, huh?
I'm in Colorado.
Yeah, Colorado, Buffalo?
Oh, yeah, a Buffalo. Oh, I think you meant Buffalo. I was going to say, Buffalo. I had a daughter who went to SUNY Buffalo.
Is that right? Okay.
Yeah.
I was a Jayhawk for years, so we were rivals for a long time until you guys jumped the Big 12 in circa 2012.
That's right. Actually, I'm married to a Jayhawk.
Are you really? Okay.
She grew up in Lawrence, Kansas, and has been true blue Lawrence, Kansas for a long time.
Yeah, crimson and blue. That's tried and true. 11 years and 3 degrees there. I got a little loyal.
Yeah, that's right.
Yeah. Good.
Yeah. Well, Lawrence is a cool town, I have to admit.
It is a cool town. I enjoyed it, but yeah, and I've been in Atlanta now for 25 years, so this is home. And yeah, absolutely. And did I see that correctly? You've been a tenured professor since 1990.
Yeah, I'm older than I look. Maybe, I hope.
Well, if I saw your resume correctly, you're probably only a couple years older than me, but my God, you got tenure pretty early in your career.
You know, in Colorado back then, rather than give you pay increases for salary, they'd rather just give you tenure.
Gotcha.
They saved a bunch of money that way, I think.
All right, so that's why I blew it. I came to Emory where they don't do anything. They never tenure you here.
Yeah, now it's gotten very hard. So I was probably, just right under the window there. So
it's all right. Okay.
Yeah. So.
Well, Steve, I do want to introduce you to the other two on the screen. That's Rahul and Anna are two of our star fellows. They are our
very good.
So this meeting is really kind of geared more for attendings, and they're kind of our fellow ambassadors. So this is not like fellow education. It's intended to be a bunch of intensivists at a bar. We're just having casual dialogue amongst each other.
I'm sorry, it's too early here for me to be drinking. I know you're a couple hours earlier.
Well, I got my bar drink going as well. But,
and I have my little coffee mug.
Exactly.
Okay. No, I'm glad to see fellows absolutely here, and it's really, that's fantastic. So good.
Well, and, these two are helping me do things out of my comfort zone. So that's how we're doing this webinar. So we're excited to get folks from all over the globe joining us today for this. Oh,
Well,
it looks
good.
like Pradeep's about to join us.
Should be fun. Should be fun.
Indeed.
Yeah.
Indeed.
Thank you, Dr. Abman, for your time. I just had a quick request. If you don't mind just testing out your share screen
Sure.
for your presentation deck, that would be greatly appreciated.
Dang.
Vote for science. Pradeep.
Yeah, that's me. That's me. Why not? Why not?
Oh,
Hi,
it
Dr.
says
Abman. How are you?
cannot- It says you cannot start screen share while the other participant is sharing.
Oh, so I've got to stop. Let me stop. All right.
Oh,
now
there we
try.
go. That'll work. Yeah, good. Very good.
Thank you. Just wanted to test it out before we go live.
Absolutely.
Good. So you're able to see the slides here and everything?
I don't see yours.
Can you see my screen right now? Or?
Not yet. If you hit share screen and maybe desktop 1, that usually is the best.
Oh, yeah. Okay. Very good. Very good. Okay.
Yes, we can see it now.
Absolutely.
Okay. Good. Yeah.
All right. Wonderful.
Yeah.
Yeah, Dr. Abman, I'm Pradeep. I had reached out to you thanks to this wonderful panel that's here.
Great. Thanks. Nice to meet you. Yes.
Nice
thanks.
meeting you too.
Yeah. So how busy is your unit right now? Are you guys busy?
We're probably running about I'd say 70 to 80% capacity pretty consistently. We don't have a shortage of ICU beds. Our sister campus, Scottish Rite, has about 52 beds. We have 36.
Uh-huh.
For most of 2020, they were really running slow, about 50% occupancy, but they kind of hit the same numbers as roughly 70 to 80% occupancy. How about you guys?
About very much the same, right immediately with the COVID issues. Of course, all of us had to adapt, which took a lot of time and demands and was very stressful. But we never ended up seeing, of course, the COVID pediatric cases in any significant numbers.
Yeah.
We were very happy that a lot of our more severe pulmonary hypertension or severe BPD infants never got sick with it.
Yeah.
It was so weird. And so we were very relieved. Yeah.
Yeah.
But we also, because we canceled, like you guys, we probably canceled all the electives and all the surgery. All of a sudden, all the, post-op stuff and things that used to keep all of us busy. We were really quiet, and I had a little bit of COVID guilt.
Yeah.
Because everyone was working so hard. Yeah.
Yeah.
So, but now
amazing.
we're pretty busy again. We're pretty busy.
Are you? Okay. Yeah. I don't know what your experience was, but because by canceling all of our elective surgeries, a lot of those elective surgeries became kind of time sensitive. They became rather urgent, not necessarily emergent.
Yeah.
And then we cranked up the OR schedules, and everything seems to have gotten up to pre-COVID levels, except for our ERs and urgent care. They are still struggling mightily. People don't want to go to the ERs. I don't know, has your experience been the same down there?
Very, very, very similar in many, many ways. And of course, we anticipated that maybe we'd be spilling over getting some adult patients because we're very close to our university hospital for our adult services on campus. And that never needed to be done, thank goodness.
Same here. We went through a lot of processes at the hospital executive level to get approval to be able to take patients up to I think we went up to age 26. We got approval to be able to take patients up to age 26 in case we needed to. Right. But luckily though our hospital adult infrastructure was bent, it did not break. So they were able to compensate.
Very good. Yeah.
Very good. So Rahul, we will only have the 5 of us on screen, correct?
That is correct. And after Dr. Abman starts his talk, we can also turn off our videos, and then there's a gallery view that can be.
Yeah, you have already have 40 people on.
Indeed.
Oh my goodness! All right, now I'm getting really nervous here.
and
you're live on YouTube.
Uh-oh, now that's trouble. It's so funny because when I only see the 4 of you, you feel like we're just having this casual conversation. Then you realize that it's
Indeed.
You have to be careful with what I say, I guess.
Indeed, and this is a little bit different for us today, and I'll kind of help everyone. I'll give us a few more minutes for more folks to log in, but we do still want this to be casual and kind of Q&A a bit, but with over 100 attendees, it would be difficult for us to have dialogues open for everybody. So we're going to try to function with the chat boxes, and if there's questions that I think will be good for us to interrupt you, I may stop you, or if you want to take a moment to stop and ask if there's questions, that'd be fine too. Well,
yeah, so feel free. Any questions that come up, however you want to handle it.
Absolutely.
So yeah,
Okay.
it's good.
And Dr. Abman, if you don't mind, I think Atul had some slides on his screen. If you don't mind hitting stop share, and then Atul, feel free to get your share going. Thank you.
All right, let's see. Let me see if I can do this right again. All right. Am I back to the slide presentation and not the presentation view? Good. Yeah, okay, good. All right. Let's see. All right, we are at 54 participants and we are at 2:01. I say we give it just a couple of more minutes, and we are live on YouTube. Okay. And Pradeep, what is this message?
Did I send you a message?
COLG. Are you pocket texting right now?
Oh, the phone's right here. No, not at all.
All right, very good. Well, this is our first time trying this approach, and it looks like we've got 56 people from all over the globe joining us. So why don't we go ahead and get started if everyone's okay. All right. All right, so on behalf of myself and Karen Walson, I want to welcome everyone to our latest installment of our joint CCM forum. We used to call it the COVID forum, but we're just going to call it our joint forum for our two campuses, Scottish Rite and Eggleston, and now also lots of folks from all over. Let's see if I can figure out how to make this work. There we go. So today we are thrilled to have an exciting guest speaker today, zooming all the way to the ATL from, I presume, Colorado, though I guess you could be from all over any over the world. And unlike our normal forums, we are not going to have a large institutional agenda, since we have invited so many guests from all over the world. And I want to thank everyone from Children's, of course, who have joined us today, but a special shout out to all of our guests from all over the world who are joining us today. We had folks from as far as Brazil at our last one, and I don't know where everybody is from this time, but we were excited to have folks from all over the world today. Happy to invite other members of our pediatric critical care family to our virtual home here in Atlanta. Just a little bit of small housekeeping, even though it wasn't going to have a large institutional agenda. Just a reminder that we did, at one of our prior forums, review our MISC guideline. Just wanted to let you guys know it's still being finalized. I do hope that we'll have something substantive to share again here for the children's folks when we reconvene in 2 weeks. A couple of acknowledgements. I want to give a shout out to Rahul Damania and Anna Rodenbow, who are panelists, and you can see them on the screen, who have helped this old man make things a little bit more modern. I now have a Twitter account and did my first Twitter post today. And today we are doing this as a webinar, which is going to allow us in the future to be able to arrange for CME, and also is allowing us to record our session for folks to be able to view that were unable to attend. So I believe this one is going to be our first one that we are having recorded. And through the power of social media, we have over 100 people registered from all over. And because we hit over 100, we are live streaming as well on YouTube, because our webinar is only for 100 participants. Thank you, Rahul and Anna, for helping with that part. I also want to say a special thank you to Pradeep, who is our social media chairman and got the word out for this talk. And a little plug for Pradeep is he has a new book out, Sedation and Analgesia for the Pediatric Intensivist. He learned from Dr. Fortenberry, so this is a very, very concise book, only 540 pages. You can buy it on Amazon, and I understand you can rent it on Kindle too, Pradeep? Mm-hmm. Awesome. All right. So special shout out to Pradeep for that.
Thank you.
All right. All right. So I want to welcome Dr. Steve Abman as our guest speaker. We were just talking, I guess you have been at Colorado for a long time, and tenured professor there since 1990. Quite impressive resume. I cannot do his resume justice. That would be a 30-minute talk in and of itself. But we're just a bunch of intensivists in a bar, and we're hanging out. And I'm trying to keep this casual, but I do want to let everyone know that he has been a professor at University of Colorado, very well respected in our field in both, well, in many things, but most notably on the management of BPD and for pulmonary hypertension. You built, you were founders for collaboratives for these two entities. And so just really thrilled to have you here. I just wanted to give a brief background of you because I can't give it your entire background justice. So in the past, I know we're going to be talking about BPD ventilation today, but I might ask you some pulmonary hypertension questions, especially because I have a couple of pulmonary hypertension patients that are frustrating me in the unit right now, but I may disturb you for that. So just a couple of ground rules. In the past, we have described our gatherings as a bunch of intensivists meeting in a bar and reminding folks not to share patient-protected information. And we've kept this pretty open for people to be able to speak. But because of the size of this event, because we have over 100 people attending, we've taken this panelist approach. So there will be the ability for me to unmute folks if need be. But ideally, the way we'd like to do the Q&A is if you could enter them in the chat box, and we'll try to compile questions for Dr. Abman. I think it would just been very difficult for us to have the ability for all 100 people to speak and interference from background. You guys have all had nice Zoom nightmares, and we wanted to avoid that. Let's see. All right, so now we can go ahead and transition. Dr. Abman, we are excited to have you speak, and I'd like you to go ahead and take over the screen. So I have to stop sharing. Hold on. And I'll let you take over, and let's have a great talk.
Great, thank you so much. And it's such a pleasure to be able to join you today. And I know these have been very, very stressful times for all of us between all this endemics and many confusion, much confusion around the election and many things going on. So appreciate your taking out some time to listen to me speak. So thank you very much.
This will keep us calm. This will be nice.
keep your mind off of these other things. How's that?
Exactly. There will be no scoring here.
So let me talk about something that's more of a team sport, where truly collaboration, unlike our politics, is very important. And that is really the care of infants with severe BPD.
Amen.
And BPD is one of those challenges that really crosses multiple disciplines, especially critical care. But our neonatology colleagues, our pulmonologists, our cardiologists, we'll talk a little bit about the team care that's really required. And how to extend that care throughout the hospital is always a challenge, right? We have a home base in the neonatal units, and yet these kids are readmitted to the PICU, or they may have been discharged and then they're admitted on a ventilator in the PICU, not a small group of kids. And so how to care for them in terms of not just the ideas behind prevention of BPD, where we try to spend so much effort in the neonatal world, but once you have established severe BPD, what's that about? How could we think about that? How should we care for them? But especially, how should we think about mechanical ventilation in that setting? And so my objectives today is to really start with a brief background about some of the things that may have changed since your residency, where you did a lot of NICU, or more recently, we have what we call the changing landscape of BPD, from the old to the new BPD of the modern era, to discuss some insights about late respiratory and cardiovascular outcomes of premature infants with BPD across the lifespan, but then to really then finally approach and talk about a physiology-based strategy for ventilator care of infants with severe BPD. But I'd like to first start off briefly with a couple of cases that are illustrative of some important features to the disease. And this is an infant who is born extremely preterm with high drops, marked congestive heart failure, severe PPHN physiology. You can see the baby is on high frequency oscillation. We're giving nitric oxide for the pulmonary hypertension. Very difficult to manage throughout the NICU stay. On the ventilator throughout the course was very difficult. We had many, many conversations with the family and other staff about futility. Should we withdraw support on this child? But over time and with care, you can see the baby now a little bit older has a trach in place, has the University of Colorado logo on its head, even though this little girl is from Nebraska. We didn't have a Kansas hat.
Well, I'm glad you didn't put a Nebraska hat on him.
That's right. And anyway, so she was discharged to a ranch in Nebraska on a home ventilator with a trach. And here she is a few years later. She's ready for having decannulation back at our institution. And here she is at follow-up. She's a ballerina, a cowgirl, a baseball player. She's doing great in school. Actually, she's just starting high school now. And she's done beautifully. And this is another case I want to talk about. Oops, let me go back here. So here's, in this regard, here's a child who had all the markers of terrible outcomes: ventilator dependency, again, recurrent problems with weaning FiO2 during her acute stages, leading to many, many discussions of what we should do in terms of her overall course. Should we withdraw care or not? And so as we think about the evolution of the new BPD as shown here from the old BPD, she really represents more of the old BPD, even though here we are years later. You could see in the old BPD, we have evidence of hyperinflation radiographically, diffuse parenchymal infiltrate, whereas now the infants who carry the diagnosis of BPD more typically have an arrest of distal lung development as shown here. Now, what's changed over time from the older period is the lung histology or pathology. And that is, one could see that you see this distal airspace looks dilated. You see fibrosis throughout the interstitium. You see significant pulmonary arterial disease. That's what this A is here, showing remodeling and changes. And now in the new BPD, we see more evidence of this dilated distal lung, less evidence of the fibrosis perhaps, but we still see vascular beds that are abnormal, and we still see the same problem of alveolar growth arrest. So in other words, over the years, over 50 years since we made the pronouncement of BPD by Bill Northway at Stanford, things have changed and improved dramatically with improved survival. And we've gone from having this understanding of BPD as a fibroproliferative disease with distal airspace issues, airway issues, many, many problems as shown here. You peel away the fibrosis and you still have this problem of impaired lung surface area, decreased alveoli, and decreased vascular growth. So how does that relate to many other cases? Well, here's a child who's a little different from our first one. And this was a college student at a major university who I actually took care of as a newborn as well, who really had minimal ventilator dependency. He came back to see us at 20 years of age, mostly because he was back home in Colorado visiting his family. And his chest x-ray shows that he has marked hyperinflation, and a CT shows sort of a mosaic perfusion pattern, some heterogeneity of lung disease, scattered areas of relative hypoperfusion and lucency with those of more dense infiltrate. And this is what his lungs look like. Not terrible, but showing chronic lung disease, despite a relatively benign early course in life. When we did pulmonary function testing, we were quite surprised. When we looked at his flows by spirometry, you could see that most of his values were at 64 or even lower of predicted. And one could see, for example, that the small airway function was markedly decreased at 14%. His FEV1 or FVC, which is a marker of airways obstruction, was about half of predicted, 53% predicted. And if you look at his flow volume loops, you see this dramatic scalloping that is obstruction to flow. Instead of a nice pattern of the volume coming out nicely and a nice curve showing here, this concavity reflects the severity of these numbers. And so it's so interesting because when we think about these two different cases, they talk to us about the surprising resilience of the developing lung in the first case, how a child who could be so severely affected, so sick early on, could have such a relatively underwhelming respiratory disease later, basically disease-free. And yet this other child with minimal ventilator support had severe respiratory distress as he got older with activity and self-limited activities, and is stuck in sort of an early adult COPD type phenotype. So there's a lot of variability in respiratory outcomes beyond the degree of prematurity alone. We need to develop better insights into the lifespan issues. That as we make our diagnosis of BPD at 36 weeks corrected age on oxygen therapy, yet what happens during infancy and childhood and as adulthood? We need to learn much more about that. And as I mentioned before, there's still a major need for developing more interdisciplinary collaborations. Well, as I mentioned before, this guy in the middle here, Bill Northway, played a major role in providing the first description of BPD in 1967. And there was a symposium at Stanford that David Cornfield organized here, which was fantastic, about BPD, the then and the next. And that is what's gone on over these 50, 55 years since its early description. And I like it because right behind him is Alan Jobe. And Alan Jobe is a neonatologist at Cincinnati who's teaching us now of what does BPD look like today? Despite all the changes and improvements and survival, what are we now facing? And I think it was really a wonderful symposium to address these issues. Now the BPD, as I mentioned, that Bill Northway described, the hyperinflation is shown here, some relative cardiomegaly from right heart failure, some striking differences in how the lobes of the lung appear at autopsy in babies who died. You have regions of these little clusters of hyperinflated lung that even though the lungs are out of the chest, they still remain distended. And yet other areas of the lung that are atelectatic edematous and have pseudo fissuring between them. When we look at the histology, as we mentioned before, you have these dilated distal air spaces with very little effort for septation. So that's the alveolar simplification. And you have the interstitium where these brown spots are blood vessels showing decreased vascular growth. So the pathogenesis of BPD is clearly, from what Bill Northway taught us many, many years ago, hyperoxia, inflammation, infection, and ventilator-induced injury. But when one looks at the key features of determinants of disease, we know that prenatal factors, such as chorioamnionitis, preeclampsia, and clearly maternal smoking are all important determinants of risk for developing BPD if you're prematurely born. In fact, a few studies of large cohorts have shown that these prenatal factors, which can be identified on the first day of life, are already setting the stage and correlate with late respiratory outcomes very strongly, suggesting in many cases there's an antenatal origin for these changes. We think there are genetic and epigenetic factors that play into that. These all then lead to disruption of growth factor signaling pathways, and these then lead to changes in alveolar growth, vascular growth, and the lung function, as highlighted in at least the second case that I showed you. And I mentioned already that there's been this apparent evolution of disease as highlighted here. And so you can see that the lungs themselves don't look terribly afflicted in most of our infants with BPD. However, this problem has not gone away and will be the subject of what we'll talk about a little bit later. What's also changed over time is that when Bill Northway was caring for these kids, if one looks at the gestational age, they were right around 32 to 34 weeks gestation. And back then, that was a challenging group of kids. High mortality, and those who survived mechanical ventilation were at huge risk for chronic lung disease. And the lungs at that stage then, at 34 weeks, are more in the saccular period, right when the alveolar formation is just beginning to occur. And so fairly late in gestation and an age now that we really have such great outcomes for. And over time with the new BPD, now we're talking about that 23, 24 weeker, where they're at the late canalicular or early saccular stage. And so these babies are being born at a time when the epithelial cells are supposed to be differentiating. There's supposed to be marked capillary or vascular proliferation. And this early stage of injury, even with the most gentle of ventilation, the most subtle levels of FiO2, the best of nutrition, injury in this window can still set the stage for chronic lung disease that follows. And indeed, there have been many, many improvements in respiratory care and outcomes in premature infants. Unlike many of the comorbidities of prematurity, however, the incidence of BPD has not changed over the past couple of decades. This is from Barbara Stahl's work, where she shows that about a 43% incidence in babies born before 29 weeks gestation and completely flat. So one could say that a reason behind this is that we're now seeing more of these early preterm babies survive. And certainly with severe BPD, like we'll be discussing shortly, you see that most of the babies in this category are really, it's enriched from babies who are born at extremely low gestational age. We still see signals of moderate and mild BPD, but you could see that the earlier you're born, the more proportion of severe BPD infants are identified at that age. So over 50 years, we've looked at many factors, oxygen, ventilation, things we mentioned. We now know that antenatal stress, as I mentioned before, and genetic or epigenetic factors play a role in developmental arrest. These then lead to either early respiratory death that technically aren't included in BPD because these babies haven't reached necessarily 36 weeks corrected age is when we make the official pronouncement of BPD. Or they could have recovery, like the first case I showed you, or they could have persistent respiratory disease. And this could look like prolonged respiratory support, need for recurrent hospitalizations. A lot of the kids that you took care of throughout your residency in the ICU all the time when they're readmitted there, but also increased susceptibility for chronic lung disease of adulthood. And then finally, we're learning more and more about some of the late triggers that are involved with these exacerbations. Ongoing issues with secondhand smoke exposure, viral infections, pollution. Your zip code matters in many ways with what your local environment is for risk for these exacerbations. So we're beginning to try to better understand what it means to have late respiratory disease after premature birth. Now we know, and there have been many studies that have shown us that there's an increased risk and need for rehospitalization. And this is a baby who's back on the ventilator in a pediatric ICU. You can see relatively hyperinflated and lucent appearing lungs with a little bit of maybe some core pulmonale that's there. And this is a baby who had been discharged just the week before, picked up a virus and back on the ventilator in the ICU. And so certainly about 58% of all of our preemie patients that we followed in this cohort were readmitted to the hospital. Most of this, as shown here, was in the first year of life, which then progressively decreases over time. However, what's really important as an intensivist is that 20% of this entire cohort were not only readmitted to the hospital, but they were readmitted to the ICU. And then of those 12% were back on ventilators all over again. So fairly significant role of the ICU in managing them and improving some of the mortality and morbidities that persist after discharge. Why do they persist? Well, we know that BPD infants who are prematurely born, that is VLBW or very low birth weight infants, have worse lung function than normals from age-matched term babies, but also from preterm infants without BPD. And you can see the striking decrease in flows as reflected by Z-scores across the panel here if you were diagnosed with BPD at 36 weeks during early adulthood. But it also means that even if you don't carry the diagnosis of BPD and you're only prematurely born, you're not off the schneid. You're still at risk for having late respiratory morbidities. Very much like the second case that I told you. Striking respiratory morbidities, despite the fact that during the NICU course, he kind of stayed under our radar. Wasn't someone we were particularly concerned about. So what happens over time and the potential for recovery, I think, is very important to consider. We don't really understand these mechanisms very well at all. A lot of basic research is going into this. But as you have a sick baby in the ICU on a ventilator trying to prognosticate, it's very difficult. And this is a nice example, I think, by CT that highlights some of these changes. This is from Rob Castile, who is from Nationwide Children's in Columbus. And he shows that this infant at 6 months has terrible, what we would call cystic lung disease or honeycomb lung, right? All these areas of overinflation, perhaps fibrosis surrounding them, maybe some edema, very dramatic lungs. And if you were prognosticating to the stage, you would say this could very well be futile lung disease. When Rob then followed this kiddo at 14 months, a lot of these so-called cysts resolved, remodeled. You can see it's still not an abnormal, a normal lung by any stretch of the imagination. You see these areas of relative hyperinflation. You see this fissuring that's present. You see dramatic hyperinflation on this cut. You can see how the diaphragm's pushed down by these huge lung volumes that are there. And then at 23 months, at 2 years of age, when Rob got a third CT on this child, you can see that the remarkable hyperinflation is still there, but you see that the parenchyma itself is changing, it's remodeling. And the kiddo's lung function was getting better over time. And so one could see there's the capacity to regenerate. We wish we knew which mechanisms, how could we turn them on, how could we avoid the toxicities to accelerate this process. But there is this intrinsic capacity to recover given supportive therapy. And I show this because it reminds me, as we're caring for our more severe kids on a ventilator, later at the 36 weeks mark or beyond, for example, that there is still capacity in many settings for recovery if we get them through their more acute or subacute illness. Now, the other piece of this I want to briefly talk about, because it has to do with life course events, and that is the idea of early impairment on lung growth may be a precursor for adult COPD or emphysema. And if one looks at FEV1 as just a marker, these aren't really specific values at all, but and you look over time, you can see that most of the growth of the lung occurs in this window of childhood and up to early adolescence, even at plateaus. And then there's a normal growth decline that many of us are experiencing right now as we get longer in the tooth here, unfortunately. But we also know this, that some COPD patients who smoke and do other things can have a rapid decline and get symptomatic COPD. But what if even under the best of circumstances, you just don't get out of the chutes right? You have early lung injury or inhibition of growth. Your lung function may plateau early, and you may not be very symptomatic, like the second case that I showed you. And yet my biggest fears of that 20-year-old college student is that he's at risk for, even with normal trajectory shown here of decline, or with reduced trajectory because of viral infection, pollution, smoking, and other things, he will end up in a very severe form of COPD. And so what do we do now that we identify these kids in this risk here to help avoid this decline remains a major challenge. And so certainly avoiding pollution, certainly avoiding vaping or smoking. And I just want to say these are not my children. That's a risk factor we have to worry about. The other thing is the vasculature. And I've always been interested in the vasculature. This is another patient I took care of who's now in his 30s. Took care of him as a preemie. And now as an adult, he is now oxygen dependent again with dramatic lung hyperinflation as shown here, very much like the COPD. Had severe pulmonary hypertension by echo. And at cath, you can see the dramatic pruning of the vasculature to his lung. Instead of nice dilated conduit arteries with many, many branches like a Christmas tree, you just don't see that kind of growth in this lung. And so certainly they're at risk for pulmonary vascular disease. And we also know that our adults are at risk for early myocardial dysfunction. Perhaps one of the most dramatic examples is from this cohort of adults with congestive heart failure, when they looked at their subgroup of patients who have a history of being born prematurely before 28 weeks, but even before, dramatic enrichment of the risk in that cohort for early heart failure. And so there are many concerns about BPD across the lifespan, established BPD, how to manage them. As intensivists, we're deeply involved with their care in between these periods of time. And then certainly as pulmonologists, how we pass them on to our adult colleagues, we need to be very aware of how we could try to better maximize outcomes that way. Well, that is sort of setting the stage then. What does it mean when you have a BPD infant with severe disease? And let's go back to the old NIH Workshop definitions of BPD as a beginning here. We've always used the terms none, mild, moderate, and severe as shown here, based on at 36 weeks gestation. Are you still on oxygen? Are you requiring some level of respiratory support? And certainly as you get into the more severe forms, there's an increasing mortality even after discharge from the NICU. And so what we've been interested in this idea, and part of what the BPD Collaborative now specifically focuses on, and many of the ideas I'll be talking about is really with my colleagues in the BPD Collaborative, who I'll talk about a little bit later, is that within the so-called severe BPD, meaning significant oxygen support at 36 weeks, some respiratory support, or even requiring invasive ventilation, there's a wide spectrum of outcomes. So we decided to divide it into two forms, the type 1, type 2, we're not very creative. But the type 2 is to identify those who are still on invasive ventilation, and it's a significant proportion of this group, and they end up having the highest mortality. But most interesting is the idea that if you look at the type 2 babies, those who at 36 weeks still need significant invasive ventilator support, that's where most of the comorbidities that are associated with BPD appear. In other words, we know that severe BPD is related to cognitive disabilities, related to death, related to other kinds of poor outcomes. And that signal is really markedly increased in babies who at 36 weeks remain ventilator dependent. So very little has been done to really think about them in comparison with what we usually teach and do in our NICU and extending into our PICUs. For example, as you think about time course from the early stages after birth of a premature baby to evolving BPD to establish severe BPD, and please don't take these numbers too seriously. I made this up. Birth, of course, the early onset, somewhere in the first couple weeks of life being where the evolution is occurring. And then we say somewhere beyond the first few weeks or month of life, you're really getting into that established phase. And I show this slide because in each of these settings, we have opportunities, prevention, modulation, and treatment. We think of all the different preventive strategies one could think of. The maternal treatments, prenatal steroids, vitamin A and caffeine, how we ventilate them when we resuscitate them in the delivery room. Early use of non-invasive ventilation. All of those things are very important for prevention. And certainly as we use what we call gentle ventilation, which we could talk about, which is more similar to what you might do in older children with ARDS, for example. Small tidal volume ventilation, more rapid rates. There are things that are there that all of those things can be done early to avoid ventilator-induced lung injury. That's its own category of kids. But then when we think about modulation, these are babies who are still ventilator dependent, still having marked respiratory distress. And suddenly we can modulate their outcomes perhaps on thinking about how to ventilate them. What's the role of NAVA? What's the role of synchronized non-invasive ventilation? Can you get them off invasive ventilation sooner? What should we target for saturations and fluids and ductus management, nutrition and steroids? And those are all issues that are involved. And then finally, establish severe BPD, which I want to really focus on. And that is, how do we use the ventilator when it's already there? Disease is there. We know the risk factors. How should we think about ventilation in each of these settings, which are really distinctly different? Distinctly different because the goals are different as well as what the needs are. The goals early on are really to not try to put a tube in that baby if not needed. Okay. If the baby needs the tube, how can we ventilate them in the most gentle way to avoid ventilator-induced lung injury while we're doing everything else that we can? But finally, when you have established disease, our goals are really, how do we make a stable baby so we could reduce the comorbidities that we're worried about? You know, brain disease and cognitive function, developmental delays, avoiding pulmonary hypertension or treating pulmonary hypertension, many issues like that. All of them have different philosophies and goals. So it's not one size fits all. It's not that NAVA works across the board or doesn't work. It's not that nasal CPAP is good or bad. It's not that high frequency is good or bad. Everything has its time, its place, but a lot of this is based on, number one, your treatment goals, but number two, the underlying physiology. We always like to say physiology matters. That becomes a code around us. And so, you know, we don't have a lot of evidence. So we say the best evidence may not be MRCTs and Cochrane analysis, but it's the physiology and gauging responsiveness. So that's what one warning I should say. What follows here is, you know, based on many of those features. So let's start. How do we think about ventilating other infants, children, and adults who have ARDS? And so this is actually a young adolescent we took care of a long time ago who has, ARDS, diffuse parenchymal infiltrate, hypoxemic, and intubated is shown here. Typical kind of X-ray that one would see. But what we learned from our adult colleagues very readily is that if you did a CT, it's not so homogeneous after all, is it? And that a CT, they taught us, there are actually a couple of different zones that are involved here, what we call a two-compartment model. So we certainly have small tidal volumes targeting the baby lung, is what they like to call it. That part of the lung that's not atelectatic, gravity dependent, maybe more edematous. But here's the lung where we're trying to use and optimize for gas exchange without overstretching it, damaging it further. So that's where small tidal volumes comes into play. Then finally, we're into prone positioning now, of course, with all the COVID story hitting. But the adults were long into prone positioning, many of us intensive care also. Neonatology may be beginning to do that. But here's where perhaps using more PEEP to begin to recruit some of this lung may be of value as well. And so how to think about these different compartments, how to treat them, certain strategies are used. What does that mean for severe BPD where it's a completely different disease? Remember the CT scan I showed you before with the multiple cysts, that was an extreme example, but look at this X-ray. This kid is already hyperinflated, diffuse infiltrate, peribronchial lesions, ground glass lesions. You can see really striking differences, and yet we're stuck on a ventilator. Different baby, different physiology, and different goals. And so we think about BPD, they are not ARDS. Even when they come in acutely with respiratory failure as an exacerbation, because they have underlying physiologic phenotypes that can contribute to their disease. For example, they often have central airways disease. Tracheomalacia, bronchomalacia are the two most common. They could have small airways disease because the small airways are remodeled, or they have mucus gland hyperplasia, which means they make a whole lot more secretions, and they don't clear them very well because the cilia are damaged. And so where you suction, how you take care of the airway, quite different from what you think about with fresh RDS or fresh ARDS. Or the idea of bronchodilators, are they reactive or not? Those are all things that can be part of what you do when you care for severe BPD. The distal airspace and vasculature, I showed you the histology of decreased alveolar and vascular growth. Certainly the pulmonary hypertension can be a big piece of this, and we'll talk a little bit about that. But these vessels aren't just abnormal because there are fewer vessels, but they could be remodeled and have striking changes in smooth muscle thickening, perhaps scarring around the vessel or obstruction. And there may be some real issues of tone and reactivity still. Even though it's chronic disease, we still have kids who could be very reactive to pH-targeted therapies or nitric oxide or things too. So that should always be in the back of your mind how you're going to approach that. And finally, control of breathing is something we don't talk about too much. Bigger issue with some of our outpatients and chronic issues, but these are kids who often have sleep disordered breathing, chest wall instability, and perhaps some diaphragm dysfunction or weakness. And so this is what we pull out as we think about the clinical approach. And these things can co-occur. This is a wonderful study that was published from the CHOP group in Philadelphia, where if you look at 3 different spheres or endotypes of parenchymal lung disease, all the X-ray changes in the lung, airways disease, mostly meaning tracheomalacia by bronchoscopy, or vascular disease, mostly meaning by pulmonary hypertension, you can see there's variable components for each of their cases where they could see either more than a quarter of them had all of these elements, and I would suspect this is actually a bigger number than this. The parenchyma itself may be the most striking thing in the absence of pulmonary hypertension or tracheomalacia can be the central component with little elements of each of these. So I show this because this is how I think about targeting the lung when I do a consult or take care of them in our ICU, and as I follow them clinically as well, as to think about the components. So how should we approach them with that understanding in mind? Well, the first step is to evaluate the underlying lung disease. And so certainly this is more for the chronic issues, but they relate to severe ventilator-dependent BPD as well, is making sure we're giving good oxygen. And the idea here is to keep SATs well above 92%. We like to target 92 to 94%, knowing it oscillates between those, of course. But 100%, we don't know what their PO2 is and could it lead to hyperoxia injury. 90%, we still see infants with pulmonary vascular hyperreactivity. Even though it's not profound desaturations in the 70s or 60s or low 80s or anything, these are babies who could still have marked vasospasm because of this exaggerated constriction because of this abnormal vascular bed. So we try to hit that sweet spot closer to 94, 95%, not letting it sit very long below 92%, but not keeping these kids on 100% by any means. PCO2, we do believe in permissive hypercapnia, and it likely contributes to pulmonary hypertension with abrupt changes or acute changes. And we've seen that in the cardiac cath lab. We've had kiddos who do not desaturate, but while they're being having their pulmonary hemodynamics assessed, they'll rapidly elevate their CO2 and have vasospasm too. So certainly buffering the CO2, ventilating them enough to take away those fluctuations would be a goal for severe disease. Whether chronically having a slightly elevated CO2 does anything abnormal still remains relatively controversial. I think of it mostly as a biomarker of more severe fragile kids, but what to do on a ventilator with severe disease, we usually let them rise. We try to avoid marked swings and fluctuations in CO2 as a goal. Aspiration, sleep studies, structural airways disease with flexible bronchoscopy, assessing airways reactivity, perhaps a role for chest CT scan. All of these are elements that I think can come to play with evaluating your kiddo who's ventilator dependent with severe BPD. And then finally, cardiac assessments I won't talk too much about, but certainly echocardiogram. Someone comes into the ICU, I want to know what their pulmonary hypertension is doing. Do they have pulmonary hypertension? I don't automatically assume they have pulmonary hypertension because even some of our babies who are ventilator dependent surprisingly have relatively good looking echoes, even though statistically more than 50% of them will have pulmonary hypertension by echo. And if you take that group and give them an acute on chronic stress, as we often see in the PICU, viral infection, acute pneumonia, all these other things, the tendency to have some element of pulmonary hypertension is even greater. So getting that early echo, drawing an NT-proBNP as a biomarker for clinical decision-making is helpful. And we could talk some other time about catheterization, MRs, how to go further. But certainly these things in a child who's in the PICU, who's either doing badly, acute exacerbation, or just as part of their serial assessments, we think that an echo and NT-proBNP are very important. And I think of this because the heart-lung-vascular interactions are key to understanding the physiology of severe BPD. In other words, we know we have high pulmonary artery pressures from lung disease, hyperinflation, atelectasis, hypoxemia. We could also have it from heart disease. Not only does it cause RV dysfunction, and these lung volumes may contribute to that, but you could have impaired LV contractility, or you could have diastolic dysfunction, which often I think is an overlooked cause of persistent pulmonary edema in these patients. The other part is shunt. What does it mean to have an ASD or a PDA in the setting of chronic lung disease? I think it's different from what we think about in otherwise healthy kids. If you have an underdeveloped lung vasculature, some element of lung hypoplasia, a given element of left to right shunt may be contributing to more injury or edema than would otherwise meet the eye. And these are all components that might relate to pulmonary edema or pulmonary hypertension. And then finally, pulmonary vascular disease itself. So the management of the ventilator itself in these infants with severe BPD is really based on these ideas that first there's a heterogeneity of lung disease, as we mentioned before. It's not simply two-compartment disease, but there's marked variability in regional time constants, and I'll show you more of that briefly. We have mixed airways and parenchymal disease with decreased surface area, that hypoplasia we talked about from alveolar simplification, risk for edema and atelectasis, tracheomalacia, diffuse bronchomalacia because of the airways issues. Airway secretions, as we mentioned before, can play a major role. Risk for aspiration, and finally, pulmonary hypertension are all components. And here's some evidence of the heterogeneity, which I think is central to how we think about ventilating these kids. Here's an X-ray of a kiddo with severe BPD. And you can see histologically, neighboring regions can be so different. Look how dilated and open these spaces are. And you can see neighboring to that, there's more inflammation, more fibrosis. So from region to region, the parenchyma can be different. And it means along those lines then, as you give a breath from a ventilator, where's it gonna go? If it's an obstructed airway, it's not gonna choose that route. If it's a stiff lung, it may not choose that route. And so your air may go into an area that's relatively more compliant. Maybe there's some increase in airways resistance here, but you end up then over distending these regions, compressing these others, and causing a lung that could look something like this. Again, the honeycomb lung is illustrated here, marked regional variability. These regions of the lung are different from these regions. You could clearly see that by the CT scan as shown here. So how to ventilate them? Well, what we often do is we'll go with these small tidal volumes, relatively rapid rate ventilation. But look what happens when I do that in the lung of a child who has BPD, where you have variable amounts of heterogeneity of, here's a lung region with normal compliance resistance, low compliance, high resistance. Highly compliant but low resistance will get most of the gas you give, but you lose this surface area for gas exchange. So low tidal volume, short inspiratory times, rapid rates, which we traditionally think lead to more gentle ventilation, avoiding VILI, end up being causes of worse distribution of gas, worse dead space ventilation, higher PCO2s, higher FiO2s, progressive regional atelectasis or overdistension. So the idea here is we go back to something that doesn't make us feel right, and that is to ventilate in a different fashion that in fresh ARDS we would never do, right? Higher tidal volume, because you want to have more gas to fill the lung. You want a big but slow breath with a longer inspiratory time. But to tolerate that, you really need slower rates. Otherwise, you'll gas trap, you'll hyperinflate, you'll end up causing some injury, but you also will be not effective. And how do we measure that clinically, of course? Lower FiO2, perhaps less atelectasis, and they ventilate better because they have less dead space ventilation because of better gas distribution. So here's an example, a kiddo I was asked to see who's a severe BPD. He's, gosh, in like 40 weeks, corrected age roughly. He's re-intubated on a ventilator, going nowhere. Look how dramatically hyperinflated his lungs are, extensive disease. Again, issues about futility were raised. Should they withdraw support? Sitting at 100% for a long, long time. He's on a rate of 30, pressure support of 39/14, or pressure limited ventilation, 39/14, I time of 0.5. So the first thing we did is this kind of rate for this old a child with mixed heterogeneous lung disease of airways and parenchyma, we said, let's slow the rate. And by slowing the rate, simply that really was the major thing that was done. The lung itself over time decompressed over the couple of weeks, increased the I time to have better distribution of gas like we mentioned before. And there was a nice drop in FiO2 to about 40%. And that had been a baby who'd been in 100% oxygen for quite a while. And so it shows you some of these small changes can make difference. This is another example of a case, and I won't go through this, I just did here. But again, here's a kid who was sitting 100% oxygen, had some atelectasis on the side, they had trouble recruiting, persisted at low tidal volumes to protect the lung. PEEP was relatively high at 14, I time was short at 0.4, again, rate of 36. Again, slower rate, begin to increase the I time progressively and give a bigger breath. So this is tolerated. FiO2 dropped very quickly from 100% to 65% and proceeded to improve over time. And so those are really markers then of things that can be done to improve disease, and especially may play a role in pulmonary hypertension. This is from a recent study where having the higher your PA pressure, the worse your survival. But in this window when we can ventilate these kids and how we ventilate them might make a difference. Even without pH-specific therapies, it could be what we do mechanically with the ventilator will play an important role. And this is something you're all familiar with. that FRC is our goal, optimal FRC. Too low or too high, you increase pulmonary vascular resistance. So again, that's the physiologic basis for more uniform and improved lung volumes, trying to avoid over-distension, but certainly having sufficient FRC will favor RV performance in that setting. How to pick your PEEP is still difficult. It has to be individualized. Again, work from Rob Castile, where he did serial CTs, and he studied the effects of high PEEP. And we've never used this level of PEEP, right? But it taught us something when he did this study acutely. Here's the BPD, and you can see these airways that are shown here. And you can see that high PEEP, he has these airways are relatively open, not normal, but they're open. But when you drop them to zero PEEP, those very same airways themselves are collapsed, obstructive. You have lowered the lung volume. You can see the diaphragms aren't so flat. But by using PEEP and having a little bit of larger lung volumes, you can paradoxically have a tethering effect or a stretching effect mechanically that favors airflow, may improve gas exchange, and may lead to more successful use of mechanical ventilation in these kids. And these are examples in the other lung here. The danger, of course, is you can't have high PEEPs and high rates in babies where, you know, you will have to have time to empty, in other words. So the risk of dynamic hyperinflation, the risk of intrinsic PEEP can lead to gas trapping as shown here. And so you have to do these in combination. In the old days, we used to try one thing at a time. But if you increase PEEP without lowering the rate, this is the kind of lung you get. And so those are some of the things that you have to balance off. If you increase tidal volume and you don't change rate, this is what you'll face often. So to summarize this approach, then the early preventive strategies of low tidal volumes, short inspiratory times, other kinds of things, those might be wonderful in some settings, but in late established BPD, due to regional heterogeneity, we believe in larger tidal volumes going towards 10 and sometimes 12 mils per kilo, longer inspiratory times, because of the airway obstruction, slower rates for better emptying and stacking of breaths, and to appreciate the complex role of PEEP in this setting, and really more aggressively avoiding hypoxemia is really important for the management. And so these other goals that we'll talk about briefly here is that our goal isn't just to get the baby off the ventilator. Acute respiratory failure, that's what we want to do, get them off the ventilator, get them extubated. Here we want to say, no, the baby will extubate when he's ready to extubate. In other words, let the baby be supportive. Get rid of the distress, the dyspnea, the retractions. Let the kiddo be held and managed. So I could interact with nursing, with mom and dad, and more tolerance of physical therapies are important. And so I think those are all goals that are different from acute forms of respiratory failure. So many questions for invasive respiratory care. When to transition strategies from this lung protective approach early on to chronic is a challenge. What is really stable disease, which is our target? And I'd argue it's mostly babies who are not retracting, become more interactive, not in distress and dyspneic. When stable, what to wean and when to commit to chronic ventilation at all. If they're tolerating non-invasive ventilation, how long is too long? How many bouts of steroids on top of non-invasive ventilation should be tolerated before committing to chronic ventilation? And so there are some problems with oh yes, I'm sorry.
Can I stop you now for a question? Dr. Raj Basu asked a good question in the chat box. Rahul, are you able to unmute and ask the question about the tidal volume? Because I kind of had the exact same question, just Raj wrote it better. But
sure. Yeah. Dr. Abman, we had a question from one of our attendings, and specifically, if you could kindly comment on how you could use VCO2 to adjust your ventilatory support, specifically the I to E ratio, given the regional variability as well as the varying time constants.
That's a great question. And so we don't have many ways of really quantifying this. And so I think a lot of this is sort of, empirical at the bedside. And it's done as a step-by-step process with close observation. We'll use the flow volume loops from the ventilator quite a bit. But these are sort of some of the theoretical aspects of what we would approach and how we would think about this. You know, there have been past efforts to use bedside assessments of lung function using esophageal balloons or measuring resistance and compliance while changing PEEP, for example. Those are all things that could be helpful. But again, we have very little data with how to really quantify some of those differences. But overall, the goal is more patient stability and comfort and less distress, as opposed to trying to acutely improve blood gases. And so that's where I think these are stepwise things that require serial and longitudinal assessments at the bedside. You know, I don't know if that helps at all, but yeah.
Thank you.
Sure, thanks.
I think it does. Yeah, thank you.
But we do need more bedside tools, absolutely. And so if you can find a marker or metric, these are things that would be really, really important. So part of the problem with caring for them is these kids, they're in acute ICUs, and yet they're often labeled as chronic kids. And so they often don't have that proactive ability for bedside care, and they get sort of lost in the shuffle. Differences in pace of illness and response to therapy. We're targeting big picture things usually at this stage, rather than shorter term like we would with acute RDS. High staff turnover, burnout, fatigue. We're learning more and more about these, but very early on, these were the poster children for what would burn out staff, in the sense that why would you go in a room where you're having blue spells all the time, baby's miserable all the time, 100%, can't be held, can't be calmed. And some of these ventilator strategies we talked about, that's exactly our goal here, is to make a more comfortable, stable baby with some of these adjustments. So different approach for that reason. Communication between attendings, rapid turnover, having teams is so vital here. And there's certainly a need for interdisciplinary approaches. And so this is what a team might look like, components from many subspecialties, having some way of regularly being involved and engaged, to communicate amongst ourselves, to trial different physiologies. Regular meetings are key, and really for the family to know what that team looks like, and to know that their questions are being addressed is vital. And a whole host of folks that I think makes for a really solid chronic lung program. And then within the PICU, working closely with the NICU in terms of exchanging notes on how to manage them is key. Again, successful treatment of BPD is synonymous with good supportive care. We call it minimal impact respiratory support, where we try to prevent infection, prevent right heart failure, promote growth and time for repair, developmental assistance. These sound like soft metrics, but really having a stable baby who's not in chronic distress is your goal. It's not necessarily a given PCO2. Every change you make doesn't need a blood gas, and yet monitoring them for these kinds of issues is really what we're trying to achieve in the long term. Stable in these babies, not having problems with cares. Every time you change the diaper, you don't have to do CPR. Fewer cyanotic episodes that BPDers are famous for. We rely less on blood gases per se. We'd like to see consistent growth for both weight and length. And when stable, we tend to first start weaning the FiO2 as a marker to having a more favorable approach to their lung disease, better FRC. Perhaps a more stable on their diuretics, that we hit the sweet spot with that. And then once they're stable on that FiO2 and comfortable, then we'll consider weaning some of the other ventilator settings and pressures. And this is really different, again, from acute respiratory distress. Does it make a difference? Well, we saw a marked step up in survival simply by initiating this kind of program in Colorado. We also saw that there was less cost. They were discharged home when you had a true ventilator care program involved with that. And we have a whole roadmap of what the family can look at. So in conclusion, then, factors that modulate the development of severe BPD and its comorbidities are incompletely understood, but are changing. And certainly if we could learn how to grow new lung better and more quickly, that'd be a home run. Ventilator goals and strategies for chronic care of ventilator-dependent children, strikingly different from our acute responses. Interdisciplinary teams are key, and certainly being aware of what I started with about the idea of how can we have a more stable kiddo who then goes home, is stable, can really grow up and have less concern about having early onset adult diseases remains one of the challenges. And certainly grateful for all the families and kids we've cared for over the years. And this is our BPD collaborative from a couple of years ago. Leif Nellen is now the leader, the chairman of the board here. And we put together a little paper, if you want to look that up, that describes many of these philosophies that I've talked about. But thank you for your attention.
Oh my God, Steve, that was incredible. Great talk. Thank you very much. I've got a couple of questions. I know Rahul's got a couple of questions lined up from the chat box.
Sure.
So my question is, you talk about the team care approach, and so I've got two questions about that for management of these chronic kids in the PICU. You're right, these chronic kids, we just don't round on them the same way we do for the acute kids. They're more complex, and I think the first day you spend a lot of time with them, and then after that it's like SOSDD. Should PICU docs have special training for the BPD patients, because the philosophy is obviously very different for ARDS. And then the other end, Pradeep, I think also put that in the chat box. Should we have an area for these chronic kids, much like in the NICU, you think about the feeders and growers differently, and that has like a more multidisciplinary approach with an ICU doc, pulmonary, cardiac, NICU, et cetera. And welcome your thoughts on that. And then Rahul has a list of other questions for you as well.
These are great. These are really very, very important questions and great questions. First of all, you stole my line for what my daily notes look like. Thank you.
SOSDD.
Actually, it's quite the opposite. What we're trying to do is teach that that these kids, even though they're chronic and we're not making changes, they're not boring patients. They're still patients that we have to be proactive in care. And yet, the way that I learned as an intensivist was you take care of the ones who are bound for ECMO, and then you have the most junior student take care of the chronic kid, right? And so we learned that that's wrong. So don't do what I used to do. No. So it really is important then to be more proactive, anticipating, and that the goals for these chronic issues and respiratory support are really, really important, can make a huge difference. And so I think the idea of having more interactions with the neonatologists is good, but the neonatologists themselves had to learn some of these approaches. But I really think bringing these worlds together is terrific and very, very important. We learn back and forth between PICU and neonatal ICU. And there are a lot of examples historically, right? Why is it that the PICU was so slow in learning how to use high frequency oscillation? When the NICU, right across the hallway usually, right? They're doing it like crazy.
Indeed.
And likewise, the idea of permissive hypercarbia, really from the PICU, especially ventilating status asthmaticus.
Right.
Why did it take so long to translate that to the NICU? So there are many things that we could learn from each other, and meeting together is always great.
Absolutely.
Early on, just having weekly conferences, doors closed, where you have brief presentations of the fellows, from the different services. You could argue the physiology. And in the old days, it'd be quite heated. I mean, who would think that a tidal volume of 10 to 12 should ever be used in a child? A peak of 14 or 16 ever should be used. How could you do that successfully? And so you discuss the pros and cons, and then the same people are back together a week later, and you say, how'd it go? And you could assess what works or doesn't. So over the years, you develop a way, an approach, and a strategy that everyone has buy-in and has input to. And that's truly how we develop the team. The biggest part of team, of course, is making sure the bedside nurses are there. And I say that because we would often in the early days have these conversations back and forth. We realize we're working off of different data sets. In other words, the NICU attending team or the PICU attending team would do this, that, or the other thing and disagree with what a consultant might say. But it's because they're really looking at a different baby.
Absolutely.
As a consultant, we might wave our hands, hey, how are things going? And then walk away, right? SOSDD. Whereas the team that's there, really can know the nuts and bolts. But if, again, as the attending with so many sick kids, or the fellow with so many sick kids, you may not know that every time this nurse has to suction the endotracheal tube, the baby is having a dying spell and is back in 100% for an hour. And so that's where having everyone in the same room, you develop a culture that way, shared ideas and approaches that you challenge and modify over time. And that's really, really vital. Can you accelerate that by having a unit within a unit is the other question. And certainly Leif Nellen and Columbus Children's does that. and it works very well for them. They have a BPD unit. We initially had specialized nurses who really like to take care of these kids. And so they would be more often assigned to these kids. But right now with our joint rounds and the way the teams are managed, we haven't physically developed a separate unit. But it's always hard because you have a 2-year-old or a 3-year-old. Should they still be in a NICU? But the nurses get bonded to the family of the baby. They know that baby. And then you suddenly are in a new environment in the PICU simply because of age and not physiology or care. And then it gets to be kind of hard. And so working these questions out, developing your local strategies with awareness of these issues, I think is the way to go.
Very good. Awesome. All right, I think Anna, you're going to actually ask some of the questions from the chat box.
Yeah, so thank you everyone for the questions you're entering into the chat box, and we'll work to get to as many of them as possible. I have a couple of questions that are related to surgical procedures related to children with BPD. So the first is, do you have guidance for the timing of tracheostomy, as it seems highly variable, unclear if timing affects outcomes? And then also, is there any role, or has anyone considered using lung volume reduction surgery for significantly inflated lungs in a child with severe BPD?
Those are great, great questions. And so here's where the team comes in, and personalized care is important. But knowing what the course has been with changes at each of the steps is important. So before you make the commitment to tracheostomy, having those conversations, when would we place the trach for this given child? And so for me, it's someone who still requires even non-invasive ventilation, who is given recurrent DART protocols or steroid bursts to help keep the baby from requiring reintubation, for example, or babies who are reintubated and seem to be so much more stable on the ventilator that you'd like to just commit to providing a longer period of stability. Those are all kind of the settings that we'll talk about this. In terms of corrected age, certainly, 40 to 44 weeks ends up being the window where most of us are pulling the trigger on these decisions. If you do it a little earlier, you just want to make sure everyone has buy-in. And sometimes the parents, for example, may not want the trach, or nurses who haven't the experience of seeing outcomes from these kids. Like in our past history, they always equated putting a trach in with futility because there was such high mortality in babies who were severe enough to require a trach. They say, why bother? And they always envision a child who is forever trach dependent. And so getting a team where it could really feed off each other and weigh and balance this presented to the family, and to give the family enough time to be on board as well. And so sometimes it does take, weeks to make the decision, trialing different things. And so we do spend a lot of time with non-invasive NAVA, for example. We will see if we could sustain growth. Some of the tipping points are spells that we can't manage otherwise, severe tracheomalacia that we can't manage otherwise, progressive pulmonary hypertension by echo despite adding pH-targeted drugs. Those would be tipping points. But it's a dynamic question and individualized question, but you get to be 36 weeks on a ventilator, heading towards 38 and 40. Those discussions are needed, I think.
Speaking of spells, I think Pradeep has a good question about that one.
Yeah, so Dr. Abman, thank you. Can you hear me?
Yes.
Yeah, thank you very much. This is very good. Quick question. When we ventilate these kids with higher tidal volume, the question that commonly, and I think appropriately asked by the respiratory therapist is, hey, the peak pressures are going really high. They are 34, they are 36. So my question for you is, ARDS folks say, hey, a plateau pressure of more than 30 is not the best thing. What is your strategy for this patient while you want to give them higher tidal volume?
That's such an important question. That's one of the central questions. And early on, when we started switching to this kind of approach, it used to drive people crazy. We all went crazy with it, right? Because we do believe in the data that suggests that, you should have these peak inspiratory pressures, and they should be limited because they're markers of overdistension of the baby lung. You know, that's why I showed the CT of the ARDS patient where you're just ventilating off this small lung within this atelectatic, edematous, boggy lung. And so that's the whole rationale from Gatnoni and others historically. Because really the CT opened our eyes, I think, saying that if we're ventilating that tiny lung within the adult lung, the baby lung within the adult lung, that small tidal volume is the way to go. And as you overdistend that, that's where you start seeing the step up and the peak pressure as a marker of overdistension. Pressure does not cause injury. It's the stretch or the phasic stretch. Yeah. And there are many ways of expressing the terminology of atelectotrauma, but barotrauma itself is more to me a readout. So as we think about tidal volume ventilation, especially in a kiddo who does not have ARDS, that has other reasons why their peak airway pressure may increase, such as bronchoconstriction, a ton of mucus you haven't gotten out, tracheomalacia, bronchomalacia, smaller airways from what we call dysynapsis. We have a differential growth of the airway in the parenchyma. All of those reasons are why, if I'm going to deliver enough gas to improve gas exchange and stabilize this kiddo, I've got to use larger volumes. So we'll tolerate higher pressures, knowing that there are many components, not just lung pressure, not just lung compliance that's reflected by it, but it's total respiratory system compliance, airways, tubing, chest wall, etc. So we will target ourselves, many centers will do this, tidal volume, and whatever we're reading out, if we have this disproportionate spike in pressure, we'll be a little more aggressive with suctioning. And for me, suctioning means not just the Ballard suctioning in line to avoid ventilator-associated pneumonias, but I think in this kiddo, because of the risk, the chronicity of the disease, the thick nature of the mucus, et cetera, I like to go through bag suctioning. I know this is against policy usually, but I think you have to get the mucus out and to help loosen it much more aggressively than ARDS. That will help lower those pressures for a given tidal volume sometimes. And so tidal volume to me is what counts, the gas exchange, lowering the FiO2, doing it incrementally. In other words, you don't have to start with 6 mils per kilo and suddenly pop up to 12 mils per kilo, but do it progressively and steadily while suctioning like crazy, while worrying and monitoring, but also then to reduce the rate, prolong the inspiratory time. And I think those are all ways that we could avoid having regional overdistension that may cause a pneumothorax, even in these older kids. So it's part of a package deal that larger tidal volume necessitates changes in rate and eye time, just as PEEP does. And so finding the sweet spot, and they should often be done in combination, as opposed to the way that we were trained often, where only one thing at a time, get a blood gas, watch, get another blood gas. You can't, it's a different scenario. So I don't know if that's an overwinded way of, but I don't worry about peak pressure, but I use it to think about how could I ventilate differently, but I still feel that incremental increases in tidal volume can be very, very helpful.
Yeah, and just a follow-up question, when you're on really high tidal volumes and peak pressures are high, do you very frequently paralyze these kids, or what's your strategy with neuromuscular blocker?
Great question, because within our BPD collaborative, which we now have, I think 23 sites, some centers, and so if I talk to Leif Nellen, for example, who's fantastic with these kids, the BPD Center at Columbus, he will paralyze these kids early on this way. I don't. And I don't because the readouts I'm looking for is to have a stable baby who will tolerate these settings and breathe more comfortable. Now, if you are completely flummoxed and lost because of the desaturations and really, an extremist, I think there is a role for acute use of sedation, paralytics, and things like that. But to me, one of the x-rays I showed you of a kiddo who was sitting on 100% oxygen, I don't know if you remember that, but had showed you a lot of slides, had the atelectasis, sitting 100% oxygen, and that kiddo was paralyzed for a couple of weeks, longer. And they were afraid to move anything, change anything. And I think it's a problem when you think about chronic strategies And I think a marker I look for of benefit beyond less distress, more comfort, fewer retractions, tolerating cares, less need for assessments of the nurses or the staff that the baby needs sedation medication. And to me, that's one of the readouts. So if you're getting frequent sedation, you require paralysis, as you adjust the ventilator, can you start taking that away more quickly and more successful? And that to me is one of the markers of a successful application of your ventilator strategy.
Yeah, thank you.
I think, Rahul, you have one more question, or was pre-sedation question the one that you were going to ask?
We do have a question in our chat box, Dr. Abman, from one of our respiratory therapists, Mitu. You mentioned the bag lavage suctioning as one of the treatments that we could use. Are there any other treatments which you would recommend, especially for a chronic ongoing basis?
Yeah, that's a great question. And again, that's what's so important, that the respiratory therapists are front and center in such a program, because it's their wealth of experience at the bedside and airway management that's so important. So I really, in fact, that's how we kicked off our program. A lot of it was really related to our collaborations with respiratory therapy. And so it's so much easier sometimes to use the Ballard suctioning, and it's so much more appropriate in fresh lung disease. But when you get to these kids, that's for the mucus and the saline. And even then, some of these babies, if you lose PEEP or have problems during suctioning, you can have desaturations. So that's where it's so important to work closely, respiratory therapy, the team, to understand who's getting suction this way, who's not, what happens when you do it. Can we obviate that in any other way? Because the mucus, a little bit of mucus causes a lot of resistance in these smaller airways, especially with the growth issues of BPD and things that we're talking about. So, so I think that how to thin it otherwise, we will have our kiddos who with recurrent, we'll call it tracheitis. We don't know, certainly you'll always find some bugs in the airway. If you see some neutrophils, maybe we'll use DNase for a period of time to help loosen the secretions. Maybe we'll trial bronchodilator before suctioning to help with that. We've gotten away from mucomist. We don't use bicarb in the airways anymore. We think they cause injury. But I think those are some of the strategies. It's individualized, done with careful observations from the therapists, nurses at the bedside, and the staff as well.
Awesome.
Yeah.
Dr. Abman, thank you very much for joining us, and thank you for being patient with us as we tried this new format. This was
great.
This was an incredible talk. Really enjoyed it. Really loved having you join our little group in this format for us. Yeah, I'm just putting up my email and Twitter handle. I don't even know how to say that really properly. I hope I said that right. But I'd love to get feedback from folks if they like this format. This is a little bit less personal, obviously, with having folks off screen and muted. But I definitely like to get feedback from folks. Please email me or reach out to me on Twitter, and we'd love to get feedback from folks on how they like this format. We want to continue to bring good content to everybody. But Dr. Abman, thank you very, very much for joining us today. Thanks again.
Well, thank you, and thanks for inviting me, and I appreciate everyone's questions, and certainly any comments or questions, feel free to reach out to me by email, and be happy to follow up on anything. So thank you very much.
Yeah, this was great. Thanks so very much.
Thank you, guys.
Thank you.
Thank you.
Anna, Rahul, thanks for working this all out for us.